You are most welcome to this video. Now, normally we don't talk about individual patients unless they've given express permission for us to do so. And hopefully their carers and doctors have given permission to do so as well. And in this case, that permission has been given, so we are free to talk about it. And the patient I'd like to talk about is called Donald Trump, 74-year-old man, somewhat overweight. Now, just before we get on to that, let's look at the current infections in the UK. So there's an extra 20,000 infections in the UK in the last 24 hours, according to the COVID symptom tracker app, and that gives us over 250,000 active cases in the UK at the moment. And in the United States, I couldn't find a figure for the number of active cases, but the number of new cases in the past 7 days, over 300,000, so perhaps a figure more than that will be currently active in the United States at the moment. So there's lots of people with COVID-19 at the moment. Let's focus on this one case who happens to be the President of the United States. And we'll have a look at particularly the medications he's on, because there's some interesting things here. I must say I'm slightly surprised by some of the medication his medical team have selected. But we'll come on to that shortly. Dr. Sean Connelly. Seems a lot of doctors in the States have names very similar to film stars, because Sean Connery, when I was young, used to be a movie actor. As far as I know, he's not a doctor. But this guy certainly is. He's the president's personal physician, Dr. Sean Connelly. And just a few things he said about the president's condition. His oxygen dropped twice. Not very much as far as we know. But he didn't need some oxygen for very long at all, meaning he did need it for some period of time. And since we've learned, he probably had it on 2 occasions when his oxygen saturations dropped slightly. He did have a slight cough. His viral load has not been established, and he has had fever. So those things we know. And the situation now from the last press conference I heard Dr. Sean Connelly give is the president has had no fever, and he's had no fever reducing meds for 72 hours. Now, I was really quite surprised when I heard this, because if someone's got a fever, you can give drugs called antipyretic drugs, and antipyretics bring down pyrexia, which is a fever. So in America, it's often paracetamol, which is Tylenol. In the UK, no, acetaminophen in America, which is Tylenol. In the UK, it's called paracetamol. Ibuprofen will do similar things, as will reasonable doses of aspirin. But what really surprised me was they said he'd had no fever-reducing medicines in the past 3 days, the past 72 hours. Now, what the doctors there were trying to illustrate, I assume, was that the president is now apyrexial. He doesn't have fever. But it amazed me that this statement implies that he has had fever-reducing medications. So the President of the United States goes into what can only be called one of the world's leading medical centres, and they give drugs to reverse the fever, which is a natural response to infection. I was absolutely amazed that they would give fever-reducing medication. Now, if they haven't, I'm sorry, do let me know and I'll correct that. But to say he's had no fever-reducing meds for the past 72 hours does somewhat imply that he had had fever-reducing medications. Now, if they've been reducing his fever, thereby, as I understand it, reducing the natural defensive mechanisms that fever induces, I would be astounded. But that seems to be the case. More detail would be welcome. They're saying no evidence of live virus in the president at the moment. Now, again, we have lots of tests for the presence of the virus, but they're PCR tests, and they are testing for the presence of the viral RNA, the viral ribonucleic acid. And I didn't know there was a test that differentiates between dead virus and live virus. It's a new one to me. I can't find it in the literature either. If you found it, do let me know. But this has been part of the problem, knowing when people are no longer infectious, because sometime after the initial disease, they can be getting residual viral RNA in their antigen samples, giving what is essentially a false positive. But the doctor here is saying there's no evidence of live virus Interesting. I assume they've got some new sophisticated tests that the rest of us don't know about. I'm not being sarcastic there. I really believe they will. I mean, it's a leading medical centre. Of course, normally people have to self-isolate for 10 days after day one, the first symptomatic day, which we believe was Friday. So that time has not yet passed. Most viral sheddings in the first 5 days. This is the time that people are most infectious. And the doctor did say the president is not out of the woods yet. Now, Boris Johnson, the Prime Minister in the UK, bear in mind President Trump is in the 5th day of his illness now. Boris Johnson didn't need hospitalised until day 9. It's absolutely typical in this condition, in COVID-19, that patients are okay for the first week and then can deteriorate in the second week. That is well known. So when the doctor says that he's not out of the woods yet, that's an understatement. The riskiest time, statistically speaking, many would say, is the second week for deterioration rather than the first week. So I would say this is still early days. It's still early days. Now, let's look at the president's medication, because we have been told this. Now, this is what we know. Remdesivir. Regen coronavirus 2, the antibody treatment, which we'll come on to. Dexamethasone. Zinc. Vitamin D. Now, we believe the president was given vitamin D. We don't know whether he was giving it in the active form or the vitamin D precursor form. And we don't know if he'd been taking it already, frustratingly. Now, we know Dr. Fauci is taking it. We believe he's taking 6,000 units a day. But did he tell the president to take it, and has the president been taking it, is an open question. So had the president been on vitamin D for some time, or was he just given it when he became ill? We don't know. We do know his doctors have said he's been taking vitamin D. He's on this drug here called Famotidine. Famotidine. Now, I know this group of drugs. I'm just not familiar with that particular one, so we'll come on to that one. Famotidine. Melatonin and daily aspirin. So 1, 2, 3, 4, 5, 6, 7, 8 things there that we know the president has been prescribed for sure because his doctors have said so. And we also believe that the president is on statins as well. Not surprising. Lots of people are on statins. I'm on statins. Perhaps most people over the age of about 55 should be on statins. There's a debate, but statins are very, very commonly used drugs. Now, getting on to the detail, let's kick off with Remdesivir. So, Remdesivir. Now, this is the antiviral drug. It's been used for several viral infections. It was originally given for, I think it was developed for Ebola, where it has some efficacy against Ebola virus, and it's since been trialled for various other viral infections with varying degrees of success, it must be said. So that's Remdesivir. It's on a 5-day course. It's intravenous infusion, we've now learned. Now he'll have just had his 4th one as I'm making this video, I think, and he'll get the 5th one after discharge, when he's discharged to the White House Medical Unit tomorrow, we believe. Well, actually, no, he's being discharged today. He'll have his 5th Remdesivir treatment tomorrow, and that will be the final one, a course of 5. Now, this has been given FDA emergency approval for anyone in hospital with COVID-19. So here we see that this is consistent with the guidelines, the FDA guidelines. And it probably needs to be given early on in the infection. It seems the earlier Remdesivir is given, the more effective it's likely to be, and the president was given it early on, so that sounds reasonable. Does this stuff work, though, is a different question. It's an expensive preparation. The drug companies have set the price, or the drug company, I can't remember which one it was now, but when I learned the price, I thought it was high. They would disagree. I think it's high. They don't. But it's an expensive drug. So the standard paper we have on this is this one from Journal of American Medical Association. Effects of Remdesivir versus standard care on clinical status at 11 days in patients with moderate COVID-19. So I guess that does describe the precedent, moderate COVID-19. Not a huge trial, 584, moderate COVID-19, Remdesivir group versus standard care group. So it was a clinical trial, so that's good. Clinical trial data, of course, is always the best data, other than some meta-analysis data, which can also be equally good or better. But clinical trials are what we need. So we have one. So what were the results? Well, the patients were basically ranked on a 7-point ordinal scale at day 11. Now, for a clinical trial, this is a bit of a subjective way to adjudicate outcome. So it'd be nice to adjudicate it on viral load or fever or some objective thing. But an ordinal scale is feeling really bad, feeling pretty bad, feeling not too bad, feeling okay, feeling good, feeling very good, feeling wonderful. That's kind of an ordinal scale. So yeah, I'm not overly impressed actually. But that's what was done. 5-day course, there's a statistically significant difference in clinical status. So a 5-day course, patients at day 11 were better and were adjudged to be better than patients not getting the Remdesivir. Now, the paper does, however, say this, and this is a direct quote, difference was of uncertain clinical importance. So the Remdesivir, there's no evidence that it reduces mortality that I know of. It's not that people are less likely to die on it, it's just that they feel a bit better at day 11, and some evidence suggests the course of the illness is a little bit shorter. So it's not a specific antiviral treatment it's an antiviral treatment, but it's certainly not a curative treatment or anything like that. And the other thing that was weird with the Remdesivir was a 10-day course. People given it for 10 days didn't do any better than people who weren't given it at all. That is weird. That is weird. So people given it for 5 days did better than people not giving it at all, not getting it at all. People who were given it for 10 days didn't do any better than people who weren't given it in the first place. So hence the president being given a 5-day course. So is that evidence-based? Yes, the 5-day course is evidence-based, but the evidence of efficacy is weak, although the side effect profile seems to be limited, so why not give it? But it's not a life and death difference as far as the data we have at the moment. Right, so that was so that's the Remdesivir. We've done that. Moving on to the Regen coronavirus 2. Now this one is antibody therapy. Now you might remember, some long-term watchers, that we've had the pleasure of interviewing the well-known virology professor Ragad from Baghdad, and way back in the first time I interviewed Ragad, I think it was probably March, could have even been February, March I think. She said all of these antiviral drugs they have at the moment probably don't work, but the one that will work is the antibodies. That's what she said. And it seems like what she's saying is sort of coming true, really, while we wait for more specific antiviral drugs. Now, MABs stand for monoclonal antibodies. Now, that's a mouthful. Now, what people do here is they take cells that produce the antibody they want, and they combine that with another cell that lives forever, a so-called immortal cell. So these cell cultures go on propagating and propagating and propagating, and they produce one type of antibody. So these cells are clones of each other. They're just all the same. They keep dividing and dividing and dividing. A clone being any two organisms which have the same genetic material. So identical twins, for example, are clones. And these cells are clones, so they produce the same type of antibody. So we end up with one particular type of antibody. That's called a MAB, a monoclonal antibody. And the antibodies are the bit that can fasten on to the virus to stop the virus from working. Having said that, there's two sorts of monoclonal antibodies in this preparation, we believe. So what is happening here is, if you imagine this is the spike, we've talked about the spike protein many times on the virus. The spike protein is the bit that actually binds into the ACE2 receptor site to infect the individual. So that's the spike protein there. Now on the spike protein, there's different protein shapes like this. Different molecular areas of the spike protein with different molecular architectures. Now what these MABs do, the monoclonal antibodies, one of them will be a shape that just fits onto that like that. So one antibody will fit onto that particular protein on the surface of the spike protein, the top of the spike protein, it will fit onto there. And then another one will fit onto there like that. They're specific to these so-called epitopes on the surface of the spike protein. Now what that means is the spike protein is now cluttered up with all this antibody. So that means that the spike protein can no longer fit into the receptor. This is the receptor binding domain part of the antibody. It can no longer fit into the receptor. So the virus can't fit into the cells, so it can't infect new cells. In other words, it neutralizes. It neutralizes the antibodies. So that's what's happening there. So that makes a lot of sense, and we're giving two of them here in this preparation. Two of these monoclonal antibodies that basically clart up the spike protein. It's been given that as an experimental name. President was given 8 grams. Now, I don't know how he was given this. The only time I've given this sort of passive immunity is something called gamma globulin injections. We used to give gamma globulin injections before we had vaccines for hepatitis B, and that was a big, painful intramuscular injection. So how that was given, I don't know. I suspect it's intramuscular injection if it's consistent with what I've done in the past. But who knows? Anyway, so 2 antibodies which attach to the spike protein as we've drawn. That's the spike protein. These are the antibodies attaching to the spike protein to neutralize it. Quite clever. Makes a lot of sense. 2 monoclonal antibodies, only available for trial use. So if you'd like some of this, tough, you can't have it because it's only available for trial use. Given as a compassionate use for the present. It's called compassionate prescribing, and we do this quite a lot. So what compassionate prescribing is if there's a drug that the doctors think would be useful, but it's not available, it's not licensed for that preparation, they can prescribe it compassionately as an exception. So this drug is not available for use. It's not a recognised approved drug. It's an experimental drug, but the doctors asked the company for some, and lo and behold they got it, and it was given compassionately. It generates what we call passive immunity. So active immunity is where you make your own antibodies to the antigen, to the virus in this case. Passive immunity is where you're given the antibodies ready-made. It's a well-known principle in immunity, passive immunity, and that means the patient enjoys a level of immunity, therefore they're not so sick while they make their own antibodies. And then that's a phenomenon called active on passive immunity. So the president will be actively immune now, he'll be making his own immunity, or I'm not saying now, but he'll be working towards that, be making his own immunity. But in the meantime, he's enjoying passive immunity from these 2 monoclonal antibodies. Hope that makes sense. It is a bit complicated. I think we went through it rationally there. So if you didn't get it, replay it by all means. But I think that makes vaguely sense. And once these antibodies are given, you give a single dose, and they last for at least a month to 6 weeks, because the antibodies circulate in the blood. So that's the good thing about this. As soon as someone's diagnosed, you give a one-off dose. That's it. One-off dose, and that's all they need. And that will carry on working for some time. And in my view, that will be it's likely to be highly efficacious. It's likely to work. Do I know that? No, I don't know that, because the trial data is not in. So far, this has been given to a few hundred patients, we believe, and we believe it's demonstrated to be safe, which is good. But we don't know it works because we haven't got the randomized clinical trials done yet. So this is being done now. It's part of the recovery trial in the UK. COVID-19 phase 3 trial to evaluate this antibody treatment. The trial started on the 14th of September. Read about it there for yourself. 2,000 patients being recruited to receive the monoclonal antibodies. 2,000 patients to act as the control group. I'd be amazed if that didn't work. I'm sure that's going to be devastatingly effective, but we don't actually know. But the president's doctors obviously believed it would work. So and so far the evidence is consistent with that. But of course that's one case. We need a trial of thousands. Dexamethasone we know works, no question about that. But we know dexamethasone is efficacious in patients receiving oxygen, or, in other words, patients that are poorly enough to have to receive oxygen, or patients that are being mechanically ventilated. Because the dexamethasone is anti-inflammatory, it will reduce the inflammation, and it's the inflammation which makes the air sacs, the alveoli, fill up with inflammatory fluid. So we know that works, and the rationale for that working is good. But dexamethasone is a steroid, it's a corticosteroid type drug, and we know that they also reduce the immune response. So when people are very poorly, when they've got this acute respiratory distress syndrome, because the alveoli are inflamed and they're filling up with fluid, then the benefit of reducing the inflammation is greater than the harmful effect of inhibiting the immune effect, the immunity. In poorly patients. But of course the president, as far as we know, is nothing like that poorly, so strange. Anyway, we know the dexamethasone works from the recovery trial again, but early use may reduce the immune response. So I must say I was a bit surprised they gave dexamethasone at an early stage. So there's evidence that dexamethasone works, but there is no evidence that I am aware of that dexamethasone works at such an early stage, yet they decided to give it. Therefore, I would not see their intervention of giving dexamethasone at such an early stage as being an evidence-based intervention. It was based on their medical experience and intuition rather than pure evidence. Yet that's what they decided to do. Now, the president did tweet today saying he felt better than he did 20 years ago. Now, that's probably true because steroids can make you feel good. Dexamethasone is a steroid. They can make you feel pretty good, it's almost superhuman. So is the dexamethasone having some psychotropic effect? That's possible. The president could, in other words, the president could feel, he could be feeling better than he actually is. That's what steroids can do. They can make you feel better than you actually are. Don't know, don't have the full clinical details. But early use inhibits immune response. I must say I am surprised they gave it, to tell you the truth, but hey, you know, they're not silly doctors. Dexamethasone in hospital, patients with COVID-19, preliminary report. So this is how we know it works. So the experimental group was that big, the standard care group was bigger. In patients hospitalised with COVID-19, dexamethasone reduced 28-day mortality amongst those who were either receiving mechanical ventilation or giving oxygen alone. And as we know, the president was only given small amounts of oxygen on 2 occasions. So was that indicated? Obviously they thought so. Does that mean the president could have had a degree of pneumonia? Wouldn't be surprising that there could be a little bit of fluid consolidation in the alveoli. That's quite conceivable, and that would mean that their decision to give dexamethasone was more intelligible. But we don't know. We only know the clinical details that they've chosen to release. So the trial did show that dexamethasone had no benefit in those who were receiving no respiratory support, so patients who were not on oxygen. and patients who were not being ventilated did not get a benefit from dexamethasone in that trial. Greatest benefit was on those being ventilated. So it had some benefit on patients who were getting oxygen, but a much greater benefit on patients who were mechanically ventilated. In other words, dexamethasone is most efficacious in the sickest patients. Right, now we've only got to zinc on this list now, but it will get quicker. The other ones are easier, so stick with it. Now zinc, background first of all on zinc. Where are we? There we are. Right, sorry, zinc. Right, role of zinc in antiviral immunity. This is from Advances in Nutrition, published in July 19. Now, this is about the effects on immunity, generally not on COVID specifically. Zinc is needed in hundreds of key enzymes, and transcription. What that means is zinc is actually necessary. Transcription is the process of reading the DNA inside the cell, reading the deoxyribonucleic acid genetic code inside the cell. So, for example, white blood cells would need to do that in order to reproduce, interestingly. But anyway, so zinc is in hundreds of key enzymes as transcription factor. Second most abundant trace element in the body. What do you think the most abundant trace element in the body is? If you think about it, it's got to be iron, hasn't it, in the red blood cells? Zinc deficiency results in a compromised immune system. This is simply stated as fact. If you're don't have enough zinc, immunity doesn't work. It's required to mount an effective viral response. Again, basically an established fact. It has direct antiviral properties demonstrated on influenza, therefore probably other viruses as well. Critical in generating an innate and acquired immune response. So innate is the non-specific immune response. The acquired is the specific immune response that you acquire after exposure. So both of these need zinc. So we see zinc deficiency certainly causes immunodeficiency. But with many of these things, it's true that a lack of zinc will cause inhibited immunity. But of course, if you give more zinc than you actually need, that's probably not going to boost immunity further. And yet the president was given that, so that's quite reasonable. Now, zinc deficiency is much more common than people think, so it is a common problem. Globally especially, it's a common problem. So zinc specifically in COVID-19, what do we know? What do we know? Limited is the answer. Preserves natural tissue barriers, so the respiratory epithelium preventing pathogen, the virus entry. So it keeps the lining of the respiratory passages in good condition. Therefore, it would be logical to assume it helps to prevent against COVID-19. But we don't know that for sure. It would just be logical to assume that. Probably useful, especially in zinc deficiency. Well, yeah, I mean, that's if zinc deficiency, it's almost certainly the case. Studies are needed. Wow, was that worth writing down? Well, these authors seem to think so. Just pointing out that they don't know. Testing of the effect of zinc as a therapeutic option for established disease. Now, they mention this for COVID-19, certainly, but for other diseases as well. Advantages, cost-effective, globally available, simple to use, limited or no side effects. Dirt cheap, it's everywhere. Lots of people are deficient of it. Deficiency in zinc does cause inhibited immunity for viral infections. It's reasonable to assume, it's overwhelmingly likely that zinc deficiency will lead to more likelihood in getting COVID-19, more severe COVID-19 if someone catches it. It would be very surprising if the coronavirus were an exception. Almost certainly true. No money in it. Zinc, readily available, every supermarket. Costs nothing. Costs essentially nothing. What would be the financial motivation to do the clinical trials? There we have it. That's my thinking on that at the moment. Vitamin D. I'd love to know the president was taking it before, but vitamin D anyway. So we've looked at this so many times. The calcifidiol or the calcifidiol, depending on how you pronounce it. 2% required admission to intensive care. So that's the active form of vitamin D. So when you take vitamin D, it's converted into a calcifidiol over time in the body over a few days. If you give it straight away, it boosts the available vitamin D straight away. So giving this vitamin D analog, 2% required admission to the intensive care unit. In the control group, it was 50%. Massive difference in this clinical trial on vitamin D. And we've looked at numerous other studies on this channel that give overwhelming evidence, to my mind, that vitamin D deficiency is immunosuppressing and will lead to more COVID-19 as well as many other diseases of an infectious nature as well. Right, now this one here, Famotidine. Now I hadn't used this Famotidine before, that's why I can't say it. But I've used two similar drugs for years and years, Cimetidine and Ranitidine. In fact, I remember when Cimetidine came out, I was a student, it was 1978. That came out, and then Ranitidine came after. Now, what these do is they reduce the amount of hydrochloric acid in the stomach. They're basically antacid pills. They reduce the level of hydrochloric acid. I must say I was surprised they're being used because there's more effective modern drugs called proton pump inhibitors, the PPIs. So these H2 inhibitors, a bit old-fashioned really, so a bit surprised, but maybe they had some special reason for doing it. That's all that is. It just stops the heartburn and the regurgitation. That doesn't surprise me at all. Many people are on that. I take one myself from time to time. It helps with heartburn and indigestion and things like that. Now, this one I didn't know much about. Interesting. Melatonin. Now, melatonin is produced by the pineal gland in the base of the brain, and the pineal gland seems to respond to light, environmental light. It's it regulates the sleep-wake cycle. So interesting. I get the feeling there's a lot to come on melatonin in the next few years. But let's have a quick whiz of what we know now. So hormone produced by the pineal gland regulates the sleep-wake cycle. So when you go to sleep, when you wake up, largely regulated by melatonin produced by the pineal gland, largely influenced by the amount of light and the timing of the light that we receive. That's why artificial lights can interfere with natural sleep patterns. But we now believe that melatonin interacts with the immune system. And we now believe that melatonin reduces inflammation. So melatonin, wake sleep cycle, but also affecting immunity, also reducing inflammation. And it does seem that people that are tired get more infections. People that work shifts, for example, can be more prone to infections. Interesting. Anyway, they decided to give the president melatonin, which, there we go. More evidence needed, of course, but I thought that was interesting. Now, safety and efficiency of melatonin in patients infected with COVID-19. This trial here is being done now in its phase 2. There's 30 patients in the trial at the moment, so we don't know at the moment. But that trial should report perhaps late 2021, so you've got a little while to wait. The last drug the patient is on, the president is on rather, is aspirin. He's on a daily dose of aspirin. Now, aspirin is a bit confusing drug. Now, I'll just tell you what I know about it. We've been given this for years, 300 milligram tablets. We put it in the patient's mouth, get them to chew it up. And rather than swallow it, we just let the drug absorb through the patient's mouth. It's absorbed much quicker that way. Single 300 milligram dose, and we give that every patient suspected of having a heart attack, a myocardial infarction, coronary arterial thrombosis. 600 milligrams is your normal headache dose. In A&E recently, we've started using 900 milligrams to try and curtail a migraine. But low-dose aspirin is 75 milligrams a day. Now, this is given to prevent blood clots. Now, my understanding is the president was on low-dose aspirin already. So in the blood, you've got all these platelets, and if they start sticking together, you can start getting a blood clot. So the aspirin at the 75 milligram a day dose, the low-dose aspirin, reduces platelet stickiness, therefore makes blood clots less likely to occur, and therefore hopefully blood clots that could potentially block off the coronary arteries to the heart are less likely to occur, and blood clots that could block off the blood vessels to the brain causing stroke are less likely to occur. It should only be used when prescribed by doctors now for what we call secondary prevention, usually after someone's already diagnosed with a disease. So whether the president has been put on that or whether he was on that already, I think he was already on that, but we don't know that for sure. Now, interestingly, the president was not put on an anticoagulant. He was not, as far as we know, he was not put on heparin, which is an anticoagulant. He was just carried on with the aspirin, which is the drug to reduce the platelet viscosity. And as far as we know, it wasn't in this report from Dr. Conley, but as far as we know, the president is on statins as well. So there we go. That seems to be the drugs that the president is taking or has been prescribed. Just to recap, Remdesivir, not that effective, expensive, but probably not very effective. The monoclonal antibody, almost certainly massively effective, but we don't have the trial data, but it makes perfect sense. I will be amazed if it's not, and Professor Ragad thinks it's going to work, so that's good enough for me. Dexamethasone we know works, but giving it in the early stages when the president wasn't receiving oxygen as far as we know, and certainly wasn't mechanically ventilated, little surprising. Giving zinc, given that a lot of people are deficient in zinc, certainly a good idea. Vitamin D, of course. If you've got an upset stomach, that one's absolutely fine. Melatonin, I simply don't know that much about melatonin. It does make sense, but we don't have the trial data. The daily aspirin, given that it was on that already, absolutely fine. And we know that blood clotting can be a problem in COVID-19. I don't know of any studies with COVID-19 and aspirin, but given that it was on it already, that's fine. And the statins we weren't told about at this briefing, so we don't really know. So if the president is doing well for therapeutic reasons now, I think the biggie is this one. I think that one's important, and I think that one's important. But that's only me. So I think the Regen SARS coronavirus 2 antibodies is important. If you're deficient in zinc and you're deficient in vitamin D, I believe they're both massively important. If you're not deficient in zinc and you're not deficient in vitamin D, you probably don't make too much difference, but we know that many people are. Good. Well, that's one patient. We can't extrapolate any general principles from one patient, but it's an interesting case example. Now, just a couple of things to finish. This is Suzanne from Strasbourg, Germany, who apparently has been watching me since February, I think. So that deserves a prize, that's for sure. Now, this other thing has come from Karen Hollywell, and Karen's got a hobby, and it's like she does things with books. Now, she's made this. It's just, I hope you can see that. But it's weird. It's like, I'll put it under there. Maybe you can, yeah, you can see it there. I can see it under there. Look, on that one. Let's just zoom out a bit. So it's like pages folded in a book, and it gives rise to this amazing artwork. So I was impressed anyway. I'd never seen that before. So thank you, Karen. That is a very lovely sort of thank you card, I guess. I'm not sure I deserve it, but it's yeah, amazing. And I will put that on my shelf. So thank you for that, Karen, very much. Thank you for listening to all of this video. Quite a long one, quite a bit of detail, but hopefully a few interesting principles for you to inform your thinking on the current situation.